Good morning, everyone. Habari za asubuhi. And karibuni sana for this morning's session. I am Dr. Hannah Mikidadi, and I have the privilege of moderating today's discussion. Our session today is called From Better Decisions to Better Health, Enabling People-Centered Care. This is a big title, but what it really comes down to is something very simple. How do we make sure that people get the right care at the right place at the right time? If we look at a global picture, fewer children today are dying, more mothers are surviving childbirth, and many diseases that were once deadly are now preventable. But despite this progress, every year an estimated 8.6 million people die from causes linked to healthcare. And here's the striking part. 5 million of those deaths are not because care is unavailable. It is because care is of poor quality, it is because care is fragmented, or simply not accessible when people need it the most. And this tells us something important. Having services in place is not enough. People are still falling through the cracks. Health journeys are very complex. They cross between homes, between facilities, community providers, pharmacies, and hospitals. And too often, patients are left to navigate these patient journeys with limited guidance and without an integrated continuum of care. And today, we are here to discuss and explore how to change that. What does it really take to build health systems that are truly people-centered? How can decisions be better supported for patients, for health workers, for governments, so that care is continuous, coordinated, and responsive? And to begin answering those questions, today we are not starting with policies, we are not starting with strategies, but we are starting with a voice from the front line. I am very delighted because today our Mgeni Rasmi, our guest of honor, is not a politician, it is not a donor, but a community health worker. He is from Kibaha municipality in Pangani ward, and he has worked as a community health worker for 6 years. Over this time, he has gained first-hand experience from supporting mother, children, and adolescents to connect them to care, bridging gaps between communities, facilities, and also accredited drug dispensing outlets. So please join me to welcome Mr. Malaki Mpumele to the stage. Karibu sana, Malaki.
Habarini za asubuhi. Shikamoni wakubwa. Sorry, I will use the national language. I'm a community health worker from Kibaha Municipal. I will go to use national language Kiswahili. Are we together? As how I introduced by the sponsor, jina langu mimi naitwa Malaki Mpumele Lulakebuka. Ni mhudumu wa afya ngazi ya jamii kutoka manispaa ya Kibaha, ambaye nimefanya kazi na D3 kwa miaka 6 kutoka 2019 mpaka 2025 tunavyozungumza. Katika majukumu yangu nimefundishwa jinsi ya kufanya kazi za afya kwenye ngazi ya jamii na jinsi ya kupunguza kifo cha mama na mtoto, jinsi ya kudhibiti kufanya kinga ya magonjwa ya kuambukiza na yasiyo ya kuambukiza, jinsi ya kuhamasisha lishe na kudhibiti utapiamlo katika community. Lakini pia nimefundishwa jinsi ya malezi ya mtoto ya awali. Malezi ya mtoto ya awali, yani ESD. Labda kwa kuanza, baada ya kuwa nimeshajitambulisha, niingie kuitambulisha D3. D3 ni shirika la kimataifa ambalo linafanya kazi katika nchi 4, na katika hizo nchi 4 ni pamoja na Zanzibar, Tanzania bara, Malawi na Zambia. Katika shughuli za D3, wahudumu wa afya ndiyo jeshi linalofanya kazi katika ngazi ya jamii, na linakabiliana na changamoto mbalimbali ambazo zinakuwa zinasoviwa kutokana na taarifa zinazotoka kwenye jamii, yani kwenye msingi wa jamii. Serikali kwa kushirikiana na D3 waliona umuhimu wa kuwepo kwa wahudumu wa afya ngazi ya jamii. Tukapatiwa mafunzo kwa ajili ya kuendelea kusustain afya ya jamii, na baada ya kuwa tumepata mafunzo tumejifunza vitu mbalimbali. Moja ya mambo tunayoyafanya katika mfumo wa D3, tuna mfumo wa kidijitali ambao unaitwa Afya and Technology, kwa kifupi tunaita Afya Tech. Mfumo huu tunautumia kwenye utekelezaji wa majukumu yetu, na tunapofanya majukumu yetu kupitia huu mfumo unatutaka tuweze kufanya usajili wa kaya. Kwanza tunafanya usajili wa kaya. Tukishafanya usajili wa kaya, mfumo unaturuhusu kufanya matembeleo ya kaya. Kwa kila mwezi tunafanya matembeleo ya kaya. Baada ya kuwa tumefanya matembeleo ya kaya, kama tukitembelea kaya tukakuta kuna mwanakaya mwenye changamoto ndogo ndogo, tunampa rufaa kutoka kwenye kaya kwenda kwenye duka la dawa muhimu. Na ile rufaa ikishaenda kwenye duka la dawa muhimu kwa mtu mwenye changamoto ndogo ndogo, kule tunakutana na mtu aliyemhudumia, anatakiwa kurudisha feedback kwa mhudumu wa afya ngazi ya jamii kwamba client uliyenitumia kwa rufaa tayari amepata huduma. Na nikishapata ile tunasema notification, mimi kama CHW natakiwa kufanya ufuatiliaji. Siishii kuangalia tu notification, natoka pale naingia tena kwenye ile kaya kuthibitisha kama ile huduma iliyotolewa au notification iliyonifikia kama imetekelezeka na kujua maendeleo ya huyo mteja. Lakini pia nikitembelea hiyo kaya nikakuta kwamba kuna mwanakaya ambaye ana dalili za hatari, ninalazimika kumpa rufaa huyo mwanakaya kwenda kwenye kituo cha kutolea huduma za afya, ambapo akishafika kwenye kituo cha kutolea huduma za afya atatibiwa, atapata matibabu, atafanyiwa vipimo na kupata matibabu. Na akishapata matibabu kuna mtu anaitwa supervisor anashirikiana na mfawidhi kutoa taarifa kwamba mteja uliyetuletea ambaye alikuwa na tatizo ABC tayari ameshahudumiwa, amefika kituoni kwetu na amepata huduma. Kwa hiyo pale ninaanza kufanya ufuatiliaji wa yule client ambaye nimempa referral kwenda kwenye kituo cha kutolea huduma za afya, kisha najua maendeleo yake na kutoa ripoti ya kila mwezi. Baada ya kusema kuhusiana na utendaji kazi wetu, lakini pia sisi kama community health worker, kama wahudumu wa afya ngazi ya jamii, yani kabla ya kumpa mtu referral tunaanza kutoa first ID, huduma ya kwanza kwenye kaya. Tunapofika kwenye kaya tumeona kwamba mtu labda ana tatizo, tunaanza kwanza kumpa ushauri, lakini tunampa kwamba huduma ya kwanza inayostahili au inayoendana na tatizo lake. Baada ya hapo, maana referral ile inataka kujua kwamba ni huduma gani umetoa kabla ya kumpa rufaa. Kwa hiyo ile fomu ya rufaa inanitaka mimi kwanza nitoe, kama nitatoa ushauri, kama nitatoa labda tuseme nitafanya vipimo. Mfano tumepewa vipimo vya kupima mfano UPT, tumepewa vipimo vya kupima BP, pressure, tumepewa vipimo vya kupima sukari. Kwa hiyo mimi ninapokwenda kwenye kaya, kabla ya kufanya jambo lolote, kama nimeona kuna dalili ambayo inaendana na zile dalili tulizosoma za magonjwa yale kama vile pressure, na lazimika kwanza kupima pressure ya mlengwa, ya mteja. Baada ya kupima ndo naandika kwenye referral, kama baada ya kuwa nimejiridhisha kwamba hana shinikizo la juu la damu, nampa referral kwenda kwenye kituo cha kutolea huduma za afya. Mfumo wa D3 kwa kushirikiana na serikali wametufundisha mfumo wa kidijitali ambao tuna uwezo wa kumtraki mteja wetu na kujua wapi alipo na anafanya nini. Na katika tunasema home visit, katika kutembelea kaya, tunajikuta kwamba tunapoifikia kaya pale ndipo tunaweza tukagundua kwamba kuna changamoto gani kuanzia kwenye swala la malezi na makuzi ya kaya. Na ndio maana tukifika pale tunahitaji kutoa hata elimu ya malezi na makuzi, kwa sababu tunakutana na wazazi wote wa pande mbili, yaani mzazi wa kiume na mzazi wa kike. Na hapa tunajenga dhana ya kusema kwamba malezi ya mtoto ni jukumu la wazazi wote wawili na sio jukumu la mzazi mmoja kama inavyochukuliwa katika jamii za kisasa. Kwa hiyo katika swala la malezi tunatamani kuona kwamba jamii inakuwa karibu na familia zao, na inapokuwa karibu na familia zao tayari tunajikuta kwamba watoto wanalelewa katika misingi bora zaidi ya kuwa mtoto anaweza kalelewa labda tuseme na mtu baki ambaye si mzazi. Mtu baki ambaye si mzazi, kuna vitu anaweza kaadapti kwa yule mtoto, na sisi tunatamani mzazi aadapti vitu kwa mtoto wake, ili kama anaweza kupokea ujuzi au upokee kutoka kwa mzazi wake. Kwa maana halisi tunapofika kwenye kaya tunashauri sana kwamba jamii ziwe na mabadiliko chanya ya kuhakikisha kwamba jukumu la kulea mtoto libaki la baba na mama wa mtoto. Na nje na masuala ya community cases tunazofanya, lakini pia tunadili na huduma za ustawi wa jamii. Tunakutana labda na changamoto kwenye kaya ambazo zinahusika labda na masuala ya watoto kufanyiwa ukatili, yani violence against children, kwamba hiyo nayo kama community health workers tunafanya kazi kwa kushirikiana na maafisa ustawi wa jamii na kuhakikisha vitendo vya ukatili dhidi ya mtoto vinaripotiwa haraka iwezekanavyo. Baada ya kusema hivyo, asanteni kwa kunisikiliza, naomba kuwasilisha.
Asante sana mgeni rasmi Malaki for sharing your important perspective. And building on his opening remarks, I would now like to proceed to introduce our panelists for today. These are experts who bring perspectives from government, from academia, and program implementation, and who works across both mainland Tanzania and Zanzibar. They each bring a unique perspective and are passionate about patient-centered care. So first we have Dr. Felix Sukums from MUHAS. Dr. Sukums is a senior lecturer, a researcher, and a consultant, and also a leader in digital health and data governance with over 20 years of experience shaping national and regional policies. And beyond his technical expertise, Dr. Sukums is also known as someone who truly bridges research, policy, and practice, ensuring that innovations in digital health actually reach and benefit the people who need it the most. Welcome, Dr. Felix. Secondly, we have Dr. Ona Machungu from the Ministry of Health in mainland Tanzania. Dr. Ona currently serves as the Assistant Director of the Health Promotion Section at the Ministry of Health. He brings a wealth of experience and leadership in community health systems, in HIV programs, and social and behavior change. He is a champion for using data and technology to improve care at every level. Karibu, Dr. Ona. Our third panelist is Mr. Abu Ismail. Abu is the head of the HMIS unit at the Ministry of Health in Zanzibar, and Abu is a visionary in digital health systems, guiding Zanzibar's efforts to align technology, policy, and practice. Welcome, Abu. And then last but not least, Ms. Nema Ringo, the Deputy Country Director of D3 Mainland Tanzania. Nema brings over 15 years of experience working closely with the government of Tanzania. She is deeply committed to ensuring that digital health solutions are not just implemented, but truly strengthening the health systems to improve care for people. So please join me in giving a warm applause to all of our panelists. Just shifting microphones. Okay, can you still hear me? Great. So all panelists, you all heard Mr. Malaki's opening remarks from Kibaha, and this reminds us that patient-centered care is not just about policy, but it's something that should be experienced every day at the front line of healthcare delivery. So to kick off our discussion, I would like all of you, with just one sentence, to explain what does patient-centered care mean to you? Do we have a volunteer to start?
All right. Good morning, everyone. Good morning. Wow, that's vibing. My name is, as I've been introduced, I'm Dr. Ona, champion in health promotion and education at the Minister of Health. Just to respond with the question that Hannah asked, that what does it entail when you say patient or people-centered care? It's basically focusing on what people need. For instance, when you came in here, you needed to sit, so we ensured that the chairs are available for you to sit. So that's one aspect of looking at it, that whatever we do should be tailor-made from the user perspective. What are the community needs? And then you provide. Thank you.
Thank you, Dr. Ona. That was more than one sentence, but it was a great addition. Thank you. Do we have a next volunteer?
Yeah, thank you very much, Dr. Anna. To me, I think you said patient care means putting individuals at the center of everything to make sure that they have quality healthcare services at the right time and at the right place.
Thank you so much, Nema, for that addition. Dr. Felix?
Thank you very much. I think we need to have patients' data so that we can focus on his or her preferences and needs.
And Abu?
Very good morning. As introduced earlier, my name is Abu Ismail from Ministry of Health Zanzibar. Speaking on patient or client-centered, just keeping the client or community at the heart of healthy system. Thank you.
Thank you so much. I think that all of your responses really come back to the patient at the center and the continuity of care. So in Malaki's opening remark, he also touched upon the role of digital technology. So my next question for all of you would really be to ask you to reflect if and how you see the role of digital technology to support people-centered care.
Thank you. Digital technology, or digital technologia. I'm joking. Actually, currently, whether we like it or not, we are impacted by digitalization. And now it becomes like, for me, I regard as digitalization as the fourth basic need of human. That's my perspective. We know we have food, shelter, and clothing, but now I'm adding internet or digital. At some point, everyone is using internet, whether you're sleeping or waking, or in all the aspects that you're doing. So digital tools basically act as a bridge between community and facilities. Maybe I'll talk more on, as we continue to discuss how we're bridging community and facilities. But at some point, we had a gap that some of the informations that were available at the community stays at the community, and we receive more of the informations that are coming from the facility. So there's no way you could bridge that gap until now, where we've been able to innovatively think of systems that are up and running, actually, to ensure that the information in the community, we know what the community needs. There's an information that at the facility, and we can bridge that gap and know how actually we need to provide our interventions in more targeted approach and be more effective. Thank you.
Thank you so much, Dr. Ona. Maybe I can see if Abu wants to volunteer to do the next remark, because I think what you mentioned about bridging the gap between community-level systems and facility-based systems is also something that deeply resonates in the context of Zanzibar, where Abu is working, which is also the context of Jamini Afya, which is one of the world's only examples of a government-owned and nationally scaled, digitally enabled community health worker system. So welcome, Abu.
Linking the client-centered, as mentioned, and digital
Thank you so much, Abu, for those remarks, sharing experiences from Zanzibar. And maybe with that, taking the question over to Nema, maybe to reflect on how, from a D3 strategic perspective, how D3's approach is using digital tools to help patients navigate their care journeys. Karibu, Nema.
Thank you very much, Dr. Anna. For D3, I think we have done a lot around that, making sure that we are empowering clients to have access to healthcare at the right time, at the right place, and right care. And we have done that by making sure that we provide a robust digital tool, and we are working together with the government, and most of our digital tools are integrated into the National Unified Community system to make sure that we are connecting clients with community health workers, but also going up to the facilities, and those who are going to the private sector also taken into consideration. That's why you heard our community health worker say that we are connecting also those clients who are visiting the adults to make sure that they also captured and they are also tracked to make sure that they receive the required services. But apart from that, we are creating real-time data through dashboard, and this real-time data help different decision makers to take action at the right time. Because the data are flowing from the community level up to the health facility level, and we have also data visualization for at the national level, which can help them to take right action at the right time. And to make sure that our initiatives are sustainable, as I said earlier, these systems are integrated within the National Unified Community System, and we have built the capacity of healthcare providers and government officials, and especially the digital team from the government to make sure that they're able to maintain and support this digital system throughout the time, even in absence of implementing partners. Thank you.
Thank you so much, Nema, for sharing that. And then to our last panelist here, Dr. Phyllis, maybe from a national policy perspective, where do you see that digital tools can really make the biggest difference for patient-centered care journeys?
Yeah, thank you very much. That's, I think it's about an hour lecture or more so, but I will respond like this. So the Ministry of Health, or the government of the United Republic of Tanzania through the Ministry of Health and President's Office has been coordinating the development and implementation of a national digital health strategy. And it has several priority areas. The current one has 11 priority areas, and holistic digitalization of health services is one of the key priority areas, looking at capturing different patient pathways from the community level, the discussion that we have in terms of what tools can we use for which purposes and who is really the user of the system. Is it an individual, pregnant woman? Is it a community health worker, frontline health workers at the facility, or planners at the council and national level? How do we ensure that we have electronic medical records capturing 360 view of the individual data so that they can be shared along the pathway? There are tools for community health workers, those are the priorities. In Tanzania mainland, we have unified community system. Now it's looking at patient-centeredness, because initially each vertical program, we are approaching the delivery of service as not targeting an individual, but targeting a disease. That's why you see different programs having different systems. But now with the unified community system, that's a priority that focuses on an individual, so that at the community level, we are using the same platform that can capture individual data and share it to the dispensary health center depending on the referral pathways. But interestingly, I visited Kibaha. One of the pathways that we missed initially is that the lessons is many patients or several patients go to dispensary, to adults, the pharmacies and drug outlets. So this pathway is in the holistic view of, for example, business. These are areas that are missed, but with the Afya Tech solution, you see the connection between community health worker and outlets, the pharmacies, but also how do we also incorporate alternative medicine and traditional healers? They are attending patients. How do we capture this? Because we don't know what kind of medications or interventions they are providing. So we also need to capture all these data points to ensure that we have 360 view of an individual, and that information can be shared to different pathways. The other critical aspect in the process is also resource management. So there are priority areas managing health financing, human resources, health commodities, to ensure that we know what we need, what we have, and how we can optimize and ensure that these required resources are availed. But of course, data governance, including sharing, ensuring data quality, are some of the priority areas that has been there for the past 15 years, and we see improvement over time on how digitalization is being approved, not on the technology side, but on the processes and workflows, but also individuals, and then technology will be the last thing to do. Thank you.
Thank you so much, Dr. Felix, for those remarks. Before we move to the next theme, I also wanted to give the opportunity to panelists to, if you have any comments or additions to the remarks that the other panelists made. I'm thinking particularly that a lot of your answers really centered around connecting community and facility, and we have had Dr. Ona, Nema speaking about the unified community system, and Abu about Gemini Afya in Zanzibar. So I wanted to ask, do you see that there are lessons learned from both of these geographies that are relevant for the other?
Thank you so much. Now with the use of unified community systems, we are able to determine health risks and health determinants at the community. Thank you, Malachi, for highlighting the business process of what the community health worker is doing. Now imagine with that data that is being collected, we who are sitting at the policy level will be able to map communities and see certain community X at certain council. With this record of BP, it's a sign of maybe in the next 5 years, we're going to succumb to an NCD kind of issue. So me sitting at the health promotion and education portfolio, it gives me a map or a mindset whereby now I need to target my implementation, maybe be it education, maybe be it promoting certain livelihood aspects or behavioral aspects to provoke change. At some point, we've been more reactive than being proactive. So most of this information, since they are they are client-centered, we will be able to aggregate data and be able to have the perspective whereby we'll be able to tackle many issues before even they reach at the facility. That's what I can add.
Thank you so much. Any reflection from anyone else?
Yeah, thank you. I think the lessons over time that we have learned is we need to invest in people, not starting with the technology. So empowerment of community health workers has been critical in using the technologies, but even the system developers, and system development, I don't mean the IT or digital health expert, but how do we all ensure that the business people, these business process owners, if it's community service delivery, health promotion unit being part and parcel, but also people are dealing with different vertical programs, which you said. How do we unify this team to ensure that we create one solution for the betterment of an individual? So how do we empower people? The skills to use this technology and data is critical, but also bringing policymakers in terms of the investment that is needed to implement this solution, I think is very critical, but better understanding of who is doing what has been an experience in Zanzibar, even in mainland. Having stakeholders forums for co-creation was a critical component because that provides an avenue as part of principles for digital development, understanding the existing ecosystem in terms of partners, what solution they are implementing, how can we create synergies, and then we can then design with people for inclusion and sustainability.
Yeah, thank you. And maybe in addition to that, I'm impressed with the way the integration is happening, reducing burden to the healthcare providers. Now we see that different stakeholders, including the implementing partner, the government, working toward one system in order to reduce the burden to the healthcare providers who were overwhelmed by several tools, several mobile phones, several applications, but now they can use just one system to navigate and to improve the quality of care to the client. Thank you.
Do you have any remark, Abu?
Thank you. Okay, thank you. Reflecting to the panel discussion, I just want to speak a little on how the revolutionary government of Zanzibar made a significant improvement to recognize the CHW CADA as national healthcare provider at community level. Again, the way the government or Ministry of Health in place determine the community, at the community there should be the only one platform so as to streamline the flow of information from the community to the national data repository system like DHS2 that we are using, and how other services that CHW need to provide to the community are scaled up every now and then. Like we have started with maternal and child health. Currently, the modules concerning to NCD due to the burden of NCD all over Tanzania and Africa, the world as whole, how we can tackle in and get data that will be used to make informed decision from the community level and to become not more on a curative but on preventive side. We see how the implementing partner, the government, the technology and the investment on CHW CADA recognition make these things in place, and upcoming reducing the burden of curative rather than preventive, and make our community and the health be in place and everybody maintain the good health as it is needed. Thank you.
Thank you so much to all of you for sharing your valuable experiences and views. I think that the panel has really been unified in their voice of talking about the importance of patient-centered care. But patient-centered care will not happen by coincidence. It will require intentional, deliberate planning and strategy. So I wanted to shift our conversation a little bit to strategy, maybe starting with Dr. Felix and Dr. Ona, who I believe can speak to this, but I'm aware that here in mainland Tanzania, the new National Digital Health Strategy has just been developed. So I would like you to reflect a little bit about how the previous lessons from the previous strategy and now the new one help support people-centered care.
Yes, so the previous strategy, of course, focused on strengthening health system through digital tools at different levels. Several lessons were learned through that in terms of improvement, for example, resource mobilization systems. If you recall, our digitalization aspects were around how do we generate or how do we manage revenues. In terms of revenue collection, HR management and health quality management. The previous strategies of implementation of solutions were that. But now the systems are focused on capturing individual level data and providing data that can be used at the point of care, while at the same time capturing the other data that is required for resource management, be it revenue, billing and payment, be it stock management, charter performance management and likes. So the focus is now, how do we connect the unconnected dots in terms of the community information systems, digital tools that are used by community health workers, but also targeting individuals. How do we have, can we create individual as literate in terms of managing their own health? Self-management tools. So if you look at what Health Promotion is doing, he will provide details, but you have client feedback systems that have been connected. So not siloed approach in targeting diseases, in targeting intervention and system, but bringing systems together, having a comprehensive system that will look at an individual, but how do you connect from the community level, primary healthcare, national systems? So efforts are underway. For instance, over 50 systems were connected and 150 use cases. When I talk of use cases, different pathways that are required for data exchange. But investment on coordination. People's interoperability has been critical. Implementation of Jamii Afya in Zanzibar, unified community systems, but electronic record system or health record systems have been brought in one room. In terms of silos implementation, you find different partners, development partners, implementing partners, perspective of academia, civil society organization, working with the government to create solutions which can seamlessly improve service delivery. But how do we also ensure coordination as critical part of investing in people to provide the necessary coordination in investing in digital health solution. Improving data quality is critical, but also managing the huge digitalization aspect by providing the required expertise from the business owners to technology providers, but also regulators or quality assurance teams.
Thank you so much, Dr. Sukums, for sharing that. And I think one of the things that I have consistently heard Dr. Sukums say over the last couple of years is that technology integration, interoperability can be difficult, but people interoperability can even be harder than that. Dr. Ona, do you have anything to add to Felix's reflection about the strategy component for mainland?
I think, thank you. Strategically, I think data utilization is the perspective where it assists mostly on how we want to continue our interventions to the community. We don't want to do everything like do everything to everyone at the same time. Why I'm saying that is because we have multiple communities with different needs. So the information that we'll be receiving will be assisting us even to channel resources, to map. When I say resources, it covers all, be it human resource, be it finance, be it how we move our targeted approaches to ensure that we deal with our community on real time. That's what I want to add.
Thank you so much, Dr. Sukums and Dr. Ona. Maybe shifting over the focus to Zanzibar. Abu, in your previous answer, you already spoke really proudly about the vision of the revolutionary government of Zanzibar, especially around professionalizing community health workers, which is something that should really be celebrated. So building on what Dr. Sukums and Dr. Ona has talked about strategy in Tanzania, how do you see strategy being able to further support people-centered care in Zanzibar? I know, for example, already that the government is really pushing for interoperability and integration in the digital health system, and that there's been immense progress in the last year.
Thank you, moderator. After being officially recognized, CHW CADA, the next phase is just to making sure the systems in a place, the people who deals with the system are trained well, and to ensure the sustainability of the system, and making sure the use of data are in place so as to manage all the aspects of health system and making informed decision based on data that are provided by the system and the workforce we have. Thank you.
Thank you so much, Abu, for sharing that. And over to Nema. You're here today representing D3, and D3 recently launched a new strategy for 2025 to 2028. We have heard representatives from government now talk about how they are approaching it. How can D3 as a partner, driven by our strategy, support and complement the work of government?
Thank you, Dr. Anna. For us, for D3, we have translated the National Digital Health Strategy for Tanzania into our strategy, and we have designed our intervention in relation to the National Health Strategy. The current Digital Health Strategy has 10. The Tanzania National Digital Health Strategy has 10 thematic areas, and we have picked 3 thematic areas to translate it into our priorities, and we are going to focus more because we have been championing better decision saves life, and now we are moving to better decision to better health. And we are intending to raise the quality of care by continuing investing in our healthcare providers to make sure that they have the right tools to offer services, and they have the capacity to use the digital tools that are already there. But we are also to improve to make sure that we have continuum of care by coordinating patient journey toward better health. But also there is another area which was a bit left out, that is feedback from client to the health system and to the different implementer. So we have also considered that by considering the individual agents to make sure that we have feedback from client to the health system as well. Thank you.
Thank you, Nema. We have now reached a point where we're also looking to engage with you, the audience. Before we move to audience questions, is there anyone in the panel that would like to make an additional remark building on something another panelist said?
Yeah, thank you very much. I know people love to hear the buzzy and the hype about artificial intelligence. And I sometimes think of how best can we think of AI not as something very new, so that it doesn't bring that hype and investment that is not focused, as we had in those who were in the Y2K. I was a bit young by then. But when we started e-health and m-health, everybody was approaching m-health in his or her own way. But with AI, we are still experiencing the same. So in the national strategy, we incorporated artificial intelligence not as a standalone intervention, but integrating into the health system by looking at the 6 building blocks, the all system building blocks that the likes of Dr. Eric can talk more of, but also extending One Health community engagement components. So AI integration into electronic health records, community health information system or digital tools, but also systems for empowerment of individuals, or systems that can be used by individuals, but also in resource management aspects. So ethical, responsible, and explainable use of AI has been incorporated in the national strategy. So partners are welcome to engage with the government to implement this in a responsible way. Developing, of course, standards and guidelines is critical so that we have agility in managing whatever AI will bring. It will help us a lot, but it has its own challenges in terms of, do we have quality data? Can it create inequity in the service delivery? We already have inequities. It may address some, but it creates more if we don't have quality, balanced data to implement such solutions. Do we have expertise to implement such solutions? So investing in the workforce is critical components, and that's why universities like MOAS are implementing degree programs on the same to really invest in the competencies that are needed. Competencies for individuals to use these tools. Individuals means the communities and community members, community health workers, healthcare professionals, health managers, and policymakers. Everybody needs a set of competencies to really manage and use these technologies. So that's in the strategy, and partners are called to really collaborate to co-create solutions that are going to empower everyone.
Thank you, Dr. Sukums. Nema, you look like you also have a comment.
Yeah, I just wanted to add with the unified community system, now we are talking about adding different modules to the unified community system. And for D3, we have added the Aramca services, the non-communicable diseases, as well as ECD, early childhood development. But there are still opportunities to collaborate and make sure that we add more components for the system to be robust, for the community health worker to have the right tool to provide services, because currently there are still modules which are missing. Thank you.
Thank you so much, Nema. Any last word from, you will have the chance to respond to questions and final comments. Okay, so with that, I would like to open up for questions. We do have some time left, so feel free to come forward with your questions. The approach that we are taking is that we will take approximately 3 questions and answer one at a time to ensure that we have enough time. And I have Aisha and Stephen here who will collect questions. I will start, could everyone who has a question raise their hands, and I will start by selecting 3. Okay, I see 3 here. 1, 2, 3. So we have a first question here. Thank you.
Thank you very much for the panelists and for the session. I want to congratulate D3 for the digital innovation, and I believe it will be a very good aspect if it will be scaled up across Tanzania in areas where it is not implemented. So my question is around community health workers. Most of our women and community members learn from YouTube and social media sources. How do we manage updating community health workers' knowledge with the right information? As we know that we have periods of changing curriculum, CHW who have learned for 2 weeks, there are others who have gone for a training of 21 days, and we are currently having a new module for training of community health workers. But in medical field, we know that for healthcare professionals, they have the way of updating their knowledge from time to time. So how can we manage updating community health workers' knowledge to make sure that they deliver the right information to those women at the community? And the second one is on the tracking. I'm very happy to hear that.
Sorry, I will cut you off for just one question.
Okay.
Samahani. We do have a QR
It's okay.
code here where you can submit the extra question. So, great question. Could you also add your name, perhaps, and where you come from?
So I'm Alex Mputa. I represent Tameniu High.
Okay, thank you so much. So the question here is around how do we ensure that community health workers are staying up to date as they deliver essential services at the front line. Do we have Dr. Ona, Nema, Dr. Ona?
Thank you so much. As we are all aware that we are currently implementing the integrated and coordinated community health workers program in the country as part of tackling one of the health system block regarding on workforce, but mainly on the community. The community health workers are provided with tablets. First of all, they are to receive the 6 months training, and all of this was set to tackle the siloed way, as it is highlighted by Dr. Felix, that mainly it was data focus, program focus, verticalization focus, but now we are streamlining it to be more government focused, coordinated by the government, so that we're able to even receive information that what is happening to the community. At some point, we were not able to even triangulate data and receive enough information from the community, because you might realize the certain community data is sitting at a certain partner that you need to at least approach the partner and ask for that information. But right now, with the integrated, coordinated, and community workers program, they'll be provided with tablets. They will use one application, one system, the unified community system, whereby we'll be able to receive all the information centrally through our dashboards, the DHIS2 and GOT Homies, and we'll be able to triangulate the information through there. So all the tablets, as you've highlighted regarding the updating themselves with information, that tablet will have all the required information to keep them updated, but not only the 6 months training that will be received at a certain particular time, they'll also be receiving orientations from time to time based on needs arose as we continue implementing the community health initiatives.
Thank you so much. Any additions from other panelists? Okay, then over to next question.
Thank you. Thank you for the insightful presentation you all have presented. But also, thank you to D3 for sharing this on this forum. So my name is Cynthia Masuka from JJ Breastfeeding Organization. As a breastfeeding specialist working closely with both clinical teams and the community at large, I've seen a very big gap in the breastfeeding knowledge and hands-on skills. My question goes directly to Mr. Ona Machangu on what is Ministry of Health taking initiatives to strengthen the breastfeeding education among health providers and the community health workers on the hands-on skills in breastfeeding. As we know, breastfeeding is very large and critical, and we are addressing so much things on maternal health, but leaving breastfeeding behind and taking into consideration, we are thinking that breastfeeding is easy and that these mothers do not face any challenges that are hard to manage. But in real sense, coming back into the ground, I have found that many mothers are facing a lot of difficulties in breastfeeding, but also since our healthcare providers do not have the right hand-on skills to help these mothers. So that's my question. Thank you.
Thank you so much for this important question. Over to Dr. Ona again. You're very popular, Dr. Ona.
Thank you so much, my sister, for that nice question. All I can say, education is not static. And that's one thing that I've been able to, and I'm trying to advocate every day, that we should not say at some point we've saturated the community with information, because also the community is dynamic. So with CHW training, one of their module is mainly focusing on ensuring how they will be educating or informing their community once they meet a community member who is either breastfeeding or is in their maternal period, either pregnancy and things like that. And we've been able to train them on reproductive, child, adolescent, and nutrition health initiatives in that regard. So the ICCHW, I am aware, within the community that they'll be rendering their service, will be able to address that issue on breastfeeding. However, as I'm sitting on the health promotion and education, I'll have to reach to you more and understand which is that community that needs to be more informed on issues of breastfeeding. As I said, education is not static, is dynamic. So we are doing every day to ensure that contents are out there to the community. On, for instance, during the World's Breastfeeding Day, we benchmark on ensuring that we push a lot of messages on importance of breastfeeding. We did community outreach. At some point we might have missed certain communities, but information is out there. All we need is to ensure that it is tailor-made to the specific community, and if some community it's at a miss, then we leverage through our health promotion coordinators that at the council level or regional level, that please go to certain community, talk to them. This is the challenge. For instance, we had a challenge around Mtwara. There were certain communities around farmers or livestock keepers that they had an issue on. We received a notification from the health facilities that most of the clients that are coming, they either have not even attended a single clinic during their time of period for 9 months. So whenever they reach the facility, it's either they're coming at the late stage or they're in a complication. And we immediately walked up, and I sent my team to do a bit of outreach campaign and provide education. So that's an ongoing work that we are doing to ensure that the community is aware. And as you know, the health
Sorry,
is
Dr.
huge.
Ona, can I ask you to wrap up?
Oh, thank you.
Yeah.
Okay, thank you so much, and thank you for that thoughtful question, because breastfeeding is definitely part of an integrated continuum of care. Yes, we have more.
Yeah, I just wanted to add that we are implementing the Early Childhood Development Program, and we have integrated the nurturing framework component in the unified community system, and that component of health and nutrition, breastfeeding, is one of the content that we have added into the unified community system. Thank you.
Thank you so much, Nema. Okay, over to our third question.
Thank you very much. My name is Ivani Kamala, Implementation Specialist with LARDA Global Health. My question is for Mr. Abu Yusufi Ismail. In February this year, 2025, a paper published by New England Journal of Medicine showed 75% reduction of maternal mortality and 40% reduction of newborn mortality by a program that was implemented in Tanzania in 30 facilities since 2020 to 2023. It showed that they used the data, training data and clinical data for clinical debriefing and continuous quality improvement. So they identified their gaps and learned from their mistakes for continuous quality improvement. Seeing that as a best practice, in your opinion, how can countries institutionalize evidence-based continuous quality improvement approaches like this program so that they are not seen as just projects, but as a part of routine health system strengthening? How can that be done?
Abu? I think also we can maybe perhaps take the larger question that comes out of this of how can we make sure that best practices and evidence coming out of research is really applied to our work going forward as government, as technical partners, as implementing partners.
Yeah, maybe I just wanted to add that digital tools might have contributed a lot to that research because currently we are using digital technology to improve services and to increase access to healthcare, and the community health workers have played a very big role in making sure that the community have the right information to access, to seek or to access healthcare at the right time, and that maybe that research might have backed off by the role of community health workers on the ground, and we should commend and compliment our community health workers who are working so hard on the ground. Thank you.
Thank you, Nima. And we also have someone representing academia here with us, Dr. Felix. What is your experience, perhaps, of the challenges and opportunities of making sure that research and evidence is informing practice?
Yeah, thank you very much. That was a good question, and as you reflected, one is there's a bridge between researchers, policymakers, and practitioners, and that bridge is being at least addressed in terms of creating platform for implementation research, and that brings the policymakers as part of research ecosystem, the practitioners, and now we are seeing even journalism coming in terms of disseminating. How do you package what was developed as a research paper to make meaning to the practitioners? But the critical aspect, I think, from the research is one of the priority areas in the current National Digital Health Strategy around data analytics, big data analytics. Systems like DHIS2, now the community health worker system in Zanzibar, in Mainland, they have collected quite good number that can, data that can be used for detailed analysis, in-depth analysis, even around the quality. Yes, we are thinking data is not trusted, it's not good quality. Have we really analyzed and identified what are the gaps and how can we address these gaps? But use the best out of the electronic medical record systems like GoToMIS now has been centralized to 7,000 plus facilities. Private facilities are collecting data. Some of them, they are paperless with research from some of my students. How can we take advantage of this data to really do in-depth analysis of various health indicators and come with findings that can inform policy practice, but also further research areas. So as academia, we're working on this, and that's why we are also creating platform of meeting with policymakers, practitioners, even civil society organizations. There could be meaningful findings that civil society organization can work on, especially around health promotion, because we need to invest in health promotion. What kind of findings can we inform, can we use, evidence can we use from research to inform health promotion interventions, be it digital or non-digital intervention? Thank you.
Thank you, Dr. Felix. Do we have a short remark from any other panelists? Otherwise, I do think that we have time for one more question. I see a gentleman here.
Yeah, thank you very much, and thank you all panelists for being here and discussing digitalization. I'm Erik van Praag. I'm a retired or recycled public health person and medic. And you see, I'm still using a book and a pen. So to your surprise maybe, and that leads me to a question, because in that way I can analyze different points of view and put things together. Now, from a primary healthcare point of view, because that is where my interest is, a level below where you are from, how do you think that info stream through digitalization from the community to the facility and the facility back to the community, how that can be analyzed at that level? Because we cannot afford to send information all to you guys and assuring that you give the feedback to the peripheral level. We need a system that at the primary health care, the health center level, district health, the CHMTs are able to analyze multiple data through a digital system, and the system in a way can help you to analyze, but still it needs a person to put that together and give feedback to where it comes from, because that's where it can be used. And that I didn't hear that clearly. So at primary healthcare level, how can we ensure that data can be analyzed and feedback can be given? I don't have a clear answer because it's a difficult question, but I like to have the point of view of the panel. Where are we going? Where should we going to ensure that? Thank you.
Thank you so much for that thoughtful question. And I think often we can say that we are data rich, but information poor, because we need to make use of that data. So who wants to volunteer as the first responder?
Thank you, Dr. Van Praag, for that good question. I'll try to answer as follows. We have a lot of data in place, from the primary healthcare level up to the national level. But as highlighted by Dr. Felix, not much is being done when it comes to how to analyze that data. But that takes me to thinking two aspects that we are working on right now. With the advancement in technology, the AI and the analytics, we want to patch the AI analytics, the AFIA AI, with the UCS. With that, we'll be able to start looking or analyzing data from just merely the community health worker who will be collecting data in a month or a quarter. We want to leverage on that. And two, we want to leverage on training. We have the health information experts at the council, at the facility, at the region, and we want also to leverage on their expertise on that. Maybe capacitating them on how to analyze data, and not only analyze, translate data for use at the primary level. Once the data is coming at the national level, it's either disaggregated data, you only see numbers, but mostly of the patient level data is being analyzed at the subnational level. Just as.
Thank you, Dr. Ona. Who wants to go next?
Yeah, I can go next. So that's really critical question around data use, which is one of the part of the theme of this conference. So I have seen improvements over time with the systems that we are implementing. So the systems are usually data capture tools, not really providing the insight. So if you look at the features now with the systems, you can get dashboards for individual users. If it's community health workers, they have their own smaller dashboard, but also data use during data entry, like providing prompts, notifications. If the vital signs or parameters are not in the normal range, the provider is notified. But data use can also go into the individual level. If the portals that we are giving individuals, how do we create that they have data that that can assist them for self-management? There is an implementation of what is called digital health wallet that will allow portability of personal health records at the individual level, but when you cross for different facilities. So that is going to be also an avenue, but having dashboards for different systems that can be accessible depending on the levels that you are. So for GoToMis, you have access at your own facility, but if it's centralized, then you have dashboard at the aggregate level, the same for DHIS too. Critical component is how do you ensure that these systems have what we call user experience. Creating system that will simplify the user's work. So that's the component of really the research coming in on how can we improve the interfaces, the number of data elements that we can capture, but how do we reuse that data that has been collected in other systems so that we are not overburdening community health workers or healthcare professionals in collecting data that is already existing in several other systems. So system interoperability is critical, but training and retraining of individuals whenever we upgrade the system. So aspect to do with upgrading individuals, upgrading the systems to ensure their maturity level in providing the necessary insights in data use, but creating also awareness of what data is available in which system so that we promote data use.
Thank you, Dr. Felix. Neymar, Abu, any contributions? Okay, I know that Dr. Faisa had a question, but unfortunately I don't think we have time for more questions. But I do want to remind everyone that there's a QR code here, so I'm sure that there's so many discussions to be had with the panelists, so please submit your questions there. So to wrap up the panel today, I would like to ask all of our panelists one last question. So if you had one wish for the future of patient-centered care in Tanzania, both mainland Tanzania and Zanzibar, it could be one insight, it could be one action, one guiding principle based on what we have discussed today. What would that be that you want the people in the room here to carry forward with them as we move forward? Or was it a difficult question?
I would say invest in people to better understand different pathways of individuals for people-centered care.
I might be a bit far, but I think currently we are still working with the parallel system, and I don't know when we are going to switch, but just posing, when are we going to trust the technology 100% and drop down the papers, because it is still giving burden to our healthcare providers, and we want to improve client experience. I don't know when we are going to switch, because we are still using the parallel system, and it is increasing the cost of implementation. Thank you.
I'll just add on a technological perspective. In a sense, currently in healthy system, we have a lot of digitally enabled system, making this system communicate to each other, integrating the systems, and seamless exchange of the data between the system will help us to be in a good position. Thank you.
Thank you, Abu. And Dr. Ona.
I might be a bit out, but integrated and coordinated community initiatives is the way to go. Using unified community system is the way to go. So let's join hands. This is the call to all partners, that the government is at the front line to ensure that all the community health initiatives are streamlined. So let's work together and make the differences at our community by ensuring that we manage and we take care of their health. Thank you.
Thank you so much to all panelists, and I know that we are all here at Tanzania Health Summit because we want to see better health outcomes for all. And I think the main takeaway we would like all of you to bring with you is that to achieve that, we need to keep the patient at the center. So I want to thank Abu from HMIS at Ministry of Health Zanzibar, Nema Ringu from D3 Tanzania, Felix Sukums from MUHAS, Dr. Ona from Ministry of Health in Tanzania, and also our Mgeni Rasmi all the way from Kibaha. So thank you everyone, and I hope you enjoyed the conversation.
Hello. Yes, yes, yes.
Good morning, good morning, good morning. We can go out for tea at Kilimanjaro. Tea is ready at Kilimanjaro. Tea is ready at Kilimanjaro Hall.
I think tushaambia tayari breakfast. I think most of them wameshaelewa. Ngoja niwaambie. Hello jamani, kuna breakfast juu.
Hii meza sasa ukishusha itakuwa chini sana, kama nyuma hawa kazito.